master's in nursing at UCLA in 2014. And her career to date has included working in orthopedics, osteoporosis, and in primary care. And she currently works with Dr. Gina Woods and others in the UCSD Osteoporosis Clinic. And I'll just end this intro by adding that in talking with a few of her mentors, there's no doubt that Cassie has a promising career ahead of her. So the title of her talk is Navigating the Facts, Understanding Concerns of Osteonecrosis of the Jaw in Osteoporosis Care. Okay, so over to you then, Cassie.
Thanks so much, Jean. So yeah, nice to meet everyone. I'm Cassie Coleman. I know I've seen several of you in the office, so it's good to see you here, and nice to meet everyone else who's joining us today. I don't have any disclosures, so I'll go ahead and jump right into the talk. Let me go ahead and share. There we go. Can everybody see that okay?
I cannot.
No? Let's see. Let me try that again.
I don't see anything.
Let's see. Sally, I see you on my screen. Are you seeing, is anyone that's on the screen seeing the slides?
No.
No.
Okay. Let's see.
This is why I always say send them to me.
How about now?
Yes.
Yes.
Oh.
Yes.
Yay.
I had to try it a different way. That's fine.
Okay.
So it's nice to meet everybody. My topic is, as Jean said, we're going to be chatting about a really common concern in osteoporosis that we hear all the time in clinic, which is osteonecrosis of the jaw. And I do want to start out with a poll that I think everybody should be seeing. So the poll, the question is, how common do you think osteonecrosis of the jaw associated with osteoporosis treatment is? And you should all be able to see that poll. Let me know if you can't. You can go ahead and choose A, 1 in 10 patients or more, pretty common. B, 1 in 100 to 1,000 patients, a little less common. C, very uncommon, 1 in 10,000 or less. And if you have no idea or you think it's something else, you can hit other.
Okay.
Go ahead and put that up. Okay. So I'll give you guys another few seconds to go ahead and weigh in. It looks like about half of us have weighed in now.
75.
I don't have the poll.
You don't?
Nope.
Jean, where are you seeing the poll? For me, I hit the polls button on the bottom. I'm not sure if anybody.
Yes, yeah. Everyone,
It's on your
in order
slide.
to actually open the poll, go to the bottom of your screen where it says polls and click on it, and it should open up right in front of you. Hopefully.
I voted for it while you guys were trying to iron out the thing.
Yeah, I had it open before the talk started.
It's
click on it.
it's on the screen for me. I already done it.
Good. Okay, perfect.
But we put our answers in the chat, right?
No, you hit the polls button and then you can actually select your answer.
Hmm.
When I entered, there was a poll. So I answered it when I came into the meeting before this.
See a polls button on iPad, message from Joanna.
Okay. Yeah, I'm not sure if everyone will be able to see it, but I think we get the idea. So we'll go ahead and end it now. I think we have about a little over 80% of us answered, so that's pretty good. We'll go ahead and end it. So about 3% of us think that 1 in 10 patients or more might experience ONJ with osteoporosis treatment, It looks like about a little under a third of us think it's a little less common, at 1 in 100 to 1,000 patients experiencing it. And then roughly half of us think it's pretty uncommon, 1 in 10,000 or less. And about 20% of us aren't sure. So we'll get into those statistics further in the talk. So, whoops. So in the talk, we're going to be addressing what osteonecrosis of the jaw actually is and a lot of misconceptions about what it isn't. We'll be talking about the specific medications that are of concern when we're talking about ONJ. We'll also be talking about the dental procedures to think about when we're talking about osteonecrosis of the jaw. We'll be talking about other causes associated with osteonecrosis of the jaw, as well as the studies and incidents behind it and ways to prevent it, and the things that we think about as healthcare providers to help you make your decision to start osteoporosis treatment. And then we'll have plenty of time at the end to go ahead and go through any questions. So you can go ahead and put those in the chat at the end or throughout the talk as you think of something. So osteonecrosis of the jaw. Osteonecrosis itself is the death of bone cells. It can happen multiple places in the body. With osteoporosis treatment specifically, we're talking about osteonecrosis of the jaw. That's the area of concern. So the American Association of Oral and Maxillofacial Surgeons, I think one person or a couple might still have their mic on. So if you can mute yourselves, that'd be wonderful. American Association of Oral and Maxillofacial Surgeons describes ONJ as exposed jawbone that can be probed or touched internally or externally in the mouth and has persisted for more than 8 weeks. And it can be a multifactorial issue. So when we're talking about osteonecrosis of the jaw and osteoporosis, we're talking about a specific type of ONJ called medication-related osteonecrosis of the jaw. And this is related to a few classes of medications, that's bisphosphonates, RANK ligand inhibitors, and romosozumab. There's a lot of reasons why people have had thoughts on why this tends to occur. The most substantiated hypotheses are related to the decrease in bone remodeling by blocking osteoclast activity, which is what each of those medications do. So our bisphosphonates, we have both oral and IV. So with oral, we're talking about our Fosamax or alendronate. We're talking about Beniva or abandronate, Actonel or Resendronate. And then IV is zoledronic acid. And there's both reclassed, used for osteoporosis treatment. There's also Zometa, which is more commonly used for cancer treatment. We have denosumab, which is a RANK ligand inhibitor. For osteoporosis treatment, we use Prolia. And we have Xgeva used for cancer treatment. And then our newest medication is romosozumab. That's a monoclonal antibody sclerostin inhibitor, also known as Evenity. And that's used for osteoporosis treatment only and in women. So other causes of osteonecrosis of the jaw, it can come about from radiation, trauma, infection, inflammation, acquired or congenital disorders, smoking, steroids, diabetes, and chemotherapy. And a lot of cases of ONJ that come up, they present very similarly. So it can be difficult to distinguish, did this come about from a medication or is there another cause? And most cases, maxillofacial surgeons who have seen several of these feel have a multifactorial origin, not just a medication or other cause. So a lot of times we get questions about a few different causes of osteonecrosis that are actually not, or causes of oral issues that are not related to osteonecrosis of the jaw. So if you have a treatment and you experience jaw pain that improves with time, that's not osteonecrosis. If you experience bone resorption or bone loss related to periodontal disease, worsening dental health such as cavities, gum disease, gingivitis, even sinusitis or exacerbations in TMJ. None of that is actually the issue that we're talking about today. So the incidence of medication-related osteonecrosis of the jaw, we know that the duration that you're on the medication might be a risk factor, but the overall incidence, regardless of the duration that you're on the medication, remains very low, similar to the numbers I'm about to tell you. So with our bisphosphonates and denosumab, we see incidence around 0.01% of people. So that's 1 in 10,000, even as low as 100,000 is sometimes published. Now, as a caveat to that, I mentioned that there's bisphosphonates used for cancer treatment as well, and denosumab formulations used for cancer treatment. Those are given in higher doses, higher frequencies. So we do see a higher incidence of ONJ with those. That's still low. It's closer to 1 to 2%. And our newest medication, romosozumab or Evenity, based on our current clinical trials, we think sits somewhere between 0.03 to 0.05% of patients experiencing medication-related osteonecrosis of the jaw. So I mentioned earlier, it can be difficult to determine if the cause of ONJ is actually medication-related. Most patients who have these have other comorbidities, potentially other dental issues that might exacerbate or contribute to its development. But one thing we do know is that in clinical trials on alendronate and Fosamax that lasted about 10 years in the early 2000s, no incidence of osteonecrosis of the jaw was found. There was then another study done starting in 2002 called the Horizon Pivotal Fracture Trial. That one looked specifically at IV zoledronic acid or reclast. And there were 3 phases to this trial. It had just under 4,000 participants in it. In the first phase, they separated those just under 4,000 people into a treatment group and a placebo group. The treatment group was treated with zoledronic acid for 3 years, which is a pretty standard treatment course as we practice today. In those groups, 1 person in the treatment group and 1 person in the placebo group developed ONJ. They then extended the trial for 6 years. They found 1 additional patient in the treatment group to have medication-related osteonecrosis of the jaw. They then extended it again for 3 more years. And in that portion of the trial, there was no additional cases of osteonecrosis of the jaw noted. So it just goes to show the overall extremely low incidence of ONJ associated with these medications, even in long-term use. The dental procedures that we think about when we're talking about osteonecrosis of the jaw, it's the ones that are really invasive to the jawbone specifically. So we're talking about tooth extractions and dental implants. Things like dental cleanings, crowns, fillings, and other less invasive procedures are not associated with osteonecrosis of the jaw. When we are talking about identifying and treating osteonecrosis of the jaw, the symptoms can range from very mild to severe. So a mild case, we're starting to see some inflammation and swelling and worsening jaw pain, which is not improving over time. At that stage, if that's ongoing for several weeks and goes untreated, you may develop an area of exposed bone in the mouth, which in the most severe cases can become infected. So there are a lot of treatments available for the entire spectrum of this condition. Mild cases are typically treated with a mouthwash, which is most commonly chlorhexidine based. More severe cases, you might need antibiotics, oral or topical. Other topical gels might also be used. And in the most severe cases, which are extremely rare, that's when you start to see more invasive dental surgeries and procedures being needed for treatment. There's a lot of things we can do and that we actively discuss with patients to prevent osteonecrosis of the jaw. One of them is routine dental hygiene. So making sure you're brushing twice a day, flossing, using your mouthwash. Another is maintaining regular dental checkups. So that's your cleanings, your exams. Typically, we advise every 6 months. Some dentists do recommend for patients.
I also, Pat, no.
Please,
If you can please make sure you're muted, that'd be great. Most often, every 6 months is recommended for routine cleanings and exams. Some dentists do recommend quarterly for patients who are receiving osteoporosis treatment. I do see pretty often in clinic, patients say, who have started treatment, they say, I'm not going to the dentist because I can't have any procedures done, including cleanings and things like that. So that's not the right mindset. We do want you to be really on top of your preventative dental care. If you do need to have an extraction or an implant, and we are talking about initiating treatment, typically we'll plan to have any extractions or implants completed and fully healed before we start treatment. If something comes about during the course of your treatment, then we'll talk about adjusting your treatment course depending on the medication you're on and depending on the situation with your dentist. A question that we often get too is, can't I just get a bone turnover marker called the C-telopeptide done, which looks at my bone remodeling to determine if procedures are safe to proceed with? The American Association of Oral and Maxillofacial Surgeons has actually moved away from that guideline, being the fact that this is a multifactorial issue. So just looking at the amount of bone remodeling alone is not reliable in their viewpoint. So when you come in to have an osteoporosis consultation, we're looking at a lot of things, and our goal is to decrease the risk of a serious or potentially life-altering fracture. So the things that we're looking at are your DEXA scan, your FRAX score, which is weighing your 10-year risk of having a major osteoporotic fracture and also specifically a hip fracture. We'll look at any history of fractures that you might have, and also just your overall health picture, any other conditions you might have that might weigh into that. For most people, for the very large majority, I would say the benefits of treating your osteoporosis and reducing that fracture risk greatly outweighs the very, very remote risk of osteonecrosis of the jaw. Often with new patients, I'll also tell them, go and have a checkup with your dentist, discuss your recommendation, in particular if you haven't seen your dentist in some time. So that's what I have today for us, and it leaves plenty of time for questions. So if you have any questions, we can go ahead and start working through those.
I have a question, if you don't mind.
Sure.
Thank you. So I know with some of the bisphosphonates, you take a pill daily. And for example, I was speaking to an oral surgeon. I might need a tooth pulled, I'm not sure. And they said, oh, 6 months after you're done with your medication, you're fine. But how is that different, though, with Reclast, where when you take it, it's in your body for, a longer period of time? And that's got a 3-year maximum dosage where the others have a 5-year. So I didn't know how, it's almost like dog years. Like how do you like think of that? Like how long after your infusion would you feel it would be safe, even if your CTX numbers were, above a certain amount? I didn't know how to judge that.
Yeah, so definitely something we weigh on a case-by-case basis. The oral bisphosphonates are given on a weekly or monthly basis, and typically, so dentists or oral surgeons will advise patients are off those for a month or a few months, depending on their individual health, specifically their oral health. So they'll look at, are there other factors they're concerned about when it comes to osteonecrosis? But typically 1 to 3 months stopping that treatment and then resuming once the area is healed is considered to be safe. With reclast, we'll typically, when we can, plan for the procedure to be done closer to the next dose being due. Same with Prolia. And then we try to go ahead and delay the next dose until that area again is healed. But it's very dependent on case by case, your fracture risk, your oral health, and all of the other factors that really go into osteonecrosis of the jaw.
Okay. So for example, if like I personally, it's almost 2 years since my first reclass. We haven't even like been to the point where, oh, I absolutely need another one, but it's suggested to get one now. If I was to need the tooth pulled, which I'm going next week for, to see if I need it pulled, and the implant, once that was all healed, everything was healing fine, I'm back to normal, no infection, no nothing. At that point, it would be fine to get the infusion. Like you want to make sure, is that the basic rule?
Typically, we'll wait until the dentist says, okay, you're healed, you're looking good, you're okay to proceed. With reclast, we have a good amount of wiggle room.
Okay. Okay. That's good. Thank you. So like the main concern is you don't want something else making your jawbone less strong when you need it to be strong to, let's say, take in the implants or be able to handle a tooth being pulled. You don't want something else that, like the bisphosphonate, that potentially could be affecting it. Is that pretty much it?
I think that's one way to look at it, but it's not necessarily something that is weakening your jaw in any way. The goal is that, we're trying to strengthen your bones overall. So it really is just very much on a case-by-case basis, weighing your risk factors, both orally and with your bones.
Okay. Yeah, I was just confused at like what causes the ONJ, like whether it's your like bones getting weaker or what it is exactly that
yeah, so we did touch on that.
Creates that.
The hypothesis that we have that is most, I think most reliable and most viable is that when you're taking these medications, your osteoclasts are blocked, so we're limiting our bone remodeling, and they think that that has a limiting factor in allowing for healing of the jaw. But again, very, very low incidence, even when you're using these medications.
Thank you. That was a great explanation. Thank you.
Thanks. Cassie, I can help moderate here for you. Let's
Thank
have
you.
you unshare, stop the share,
Okay.
so then we can see. And so folks who are new, you can do the raise hand feature and Cassie will see that. But also I can help more if I read questions from the chat. So it's your call on what you want to do.
Yeah, so let's see.
All right. All right, for someone who's never taken any osteoporosis drugs but has had trouble with implants falling out, more likely, implant falling out, likely, would this person be more likely to have ONJ if they begin Prolia, for example? Someone that's had issues with, say, maybe certain dental procedures.
Well, I think that would go into kind of the case of where we really rely on our oral surgeons to weigh in on this, because most cases are multifactorial. So if they felt that there was a reason that you may already be at risk of developing ONJ for other reasons, they may recommend that adding the additional risk of an osteoporosis medication may not be advisable. But typically, the general mindset is that the additional risk associated with osteonecrosis of the jaw related to osteoporosis medications is really low. And so most often, oral surgeons and dentists say that it's considered safe.
Okay. Maybe a quick one. Can you please clarify which mouthwash is used Is that an over-the-counter purchase, or is that something that the dentist has to prescribe?
Yeah, they would only be prescribing that if there was concern or identification of an early stage of osteonecrosis of the jaw. Often it's a chlorhexidine-based mouthwash. It can also be an antibiotic rinse. But that is something that would be prescribed based on an actual incidence, not something that should be used routinely.
Okay. Okay, you mentioned that ONJ risk with Evenity is 0.03, ranging up to 0.05. I think that's what that's supposed to be. How does that risk compare with other osteo medications?
So it's pretty similar. The risk associated with bisphosphonates and denosumab would be somewhere around 0.01 to 0.03. So you're really talking about a very similar risk ratio.
Okay. Okay, question about someone that is taking Alendronate and also has sleep apnea and is using the apparatus for that, and also wears a lower bite retainer to prevent grinding. Is there more risk for that person in developing ONJ?
Not related to the bite retainer. If you're using a CPAP and your dentist notices any concerns about inflammation or dryness in the mouth, that would be kind of a separate concern. And they would go ahead and discuss that with you and probably recommend maybe they'll recommend quarterly cleanings and exams and that type of thing.
Okay. Is it beneficial to be on Forteo when getting an implant?
There's some studies that are starting to show that perhaps Forteo might help with healing. We don't have a lot of robust data yet. Kind of a concept that's starting to come out, but not something that is in routine practice just yet. There's just not enough data.
Yeah. And just for everyone's knowledge, Forteo is a bone builder. Okay. So a potent medicine for building bone. Okay. Does someone with osteoporosis, does it cause more dental issues such as loosening of teeth, or no?
No, I think I touched on this. Okay. We get this question a lot, and no. Using osteoporosis medication will not worsen your overall dental health.
All right. And then a similar question, a question from Linda for the previous one. Is it possible to switch from Fosamax, Alendronate, to Evenity to reduce ONJ risk?
It would be possible. We wouldn't typically do that. So Evenity is used in more cases of severe osteoporosis, whereas we typically, for most patients, will use Fosamax or Alendronate in a case of more mild to moderate osteoporosis or even osteopenia. So it is possible to do it, but unlikely would not be what's recommended for fracture risk.
Okay.
And also the variance in fracture risk would be pretty negligible. Or I'm sorry, the variance in osteonecrosis of the jaw risk would be pretty negligible. So not something that would be typically done for that reason.
All right. I just scroll through, a lot of people had entered the poll questions on this. Yeah, so going forward, when we do a poll, now that I know how to do it and can get it on, we will do it with responses in a box that appears after the poll is created. I think what happened, I was kind of practicing on my account to do it, and I had inserted an example that we might use, and I guess that just popped up automatically because I'm the one that schedules the meeting from my account. So that
makes sense.
Probably what happened.
And I would have thought you could do more than one, so I wouldn't have thought that would be an issue, but
yeah,
now we know.
Yeah. Okay, so from Mary, good question here, she asked what CTX score, and I think she probably means what CTX level is safe to not have to worry about ONJ. How long should you wait after reclass infusion to have a tooth pulled and implant put in? So good.
Yeah, so I mentioned this too. So the oral and maxillofacial surgery group, they put together a new position paper related to medication-related osteonecrosis of the jaw back in 2022 was their last update. And at that point, they felt that the CT-lipeptide or CTX, which is looking at bone remodeling, is not an adequate guideline as far as making any sort of decisions regarding moving forward with implants or extractions, because of the fact that osteonecrosis is so multifactorial. So it's really not a reasonable data point to say yes or no, we can proceed with this.
Okay, good. All right, that's really clear then. Okay, family history. So Jane asked where she has had an aunt that was diagnosed with ONJ. How much of a link might there be for increasing her risk for ONJ?
It really kind of depends on what caused the ONJ. If you have similar oral health, if she had a lot of gingivitis or periodontal disease, tooth loss, that kind of thing, and developed ONJ, and you seem to be inheriting a lot of those same traits, yes, then there is a familiar risk factor involved with that. We don't know the amount to what, though.
Okay. All right. Question, does Forteo affect the teeth? Maybe positively or negatively?
Forteo works on stimulating your osteoblast activity. It is not decreasing osteoclast activity. So we do not worry about osteonecrosis of the jaw when we are looking at Forteo or Tymlos, which are teriparatide and abaloparatide.
Okay. Carol asked that she has been told that it's been found there's some evidence of ONJ in people who have an existing implant. Thoughts on that? Awareness of any data?
I've been told, I see that question, let me read it. I've been told they have found some evidence on ONJ with people who have an existing implant. I think she's saying that there's concern about ONJ in people who have already had an implant placed and healed and then are starting treatment. I'm not sure if she means they started treatment following the implant or during treatment.
This question's from Carol, if you want to.
Yeah. Well, I had an implant several years ago that took, well, no, okay. I have two questions up there. One is my dentist told me that it was for patients with existing implants, they have found some evidence of ONJ.
Not to my knowledge. If the implant has already been positioned and fully healed and then treatment has started, then that is understood to be safe with similar data and incidents that we were discussing earlier. So pretty low in the neighborhood of, 1 in 10,000 and below.
Okay, so my other question was that okay, my mind just went blank there, but I had an implant done several years ago, and I had to have 3 bone grafts over a period of several months in my jaw, my teeth. And I had a tooth pulled, and so I had a lot of I had the bone grafts over a period of several months. Now I'm leery of having any treatment for my osteoporosis because I've had a lot of trouble with my jaw, with my teeth in all my life.
And when you had all of these bone grafts and implants done, it sounded like you hadn't started treatment at that time, or you had?
No.
Okay. I think if your dentist feels comfortable, they would feel that the additional risk of adding on a osteoporosis treatment would not make a substantial difference in the risk of osteonecrosis.
So even though it's quite possible, I will need to have more invasive dental work done at some point.
If it's like you're thinking of having that in the next handful of months up to a year, depending on what treatment was recommended for you, then it may be a situation where we would say, go ahead and complete that, and then we would consider beginning treatment.
But I'm already in treatment. If I'm already in treatment.
If you're already in treatment, it would vary a lot based on what medication you're on and the overall picture of what your DEXA scans are looking like, your overall fracture risk, and what's going on in your teeth. So we can't really give individualized advice here, but it does become a little bit complicated, and we do weigh all of these factors very carefully to determine the most safe course of action.
Okay, thank you.
Mm-hmm.
How long after a tooth extraction or an implant should treatment begin? And treatment for osteoporosis treatment.
Usually with extractions, it's a couple of months, sometimes less. And then with the implants, usually similar, 2 to 3 months, we can go ahead and start. We just wait for the dentist to give us the go ahead as far as looking at how your mouth is healing and any x-rays that they're doing to make sure there's no issues before we begin. But it's usually around that time frame.
Okay, what are some early signs of ONJ? You may have touched on that, such bad breath, bleeding gums.
Yeah, it would be pain that's developing in the jaw that's not improving, or swelling to the jaw that's also not improving. Those would be the earliest signs.
Okay.
Bad breath and bleeding gums would likely not be associated. That sounds more like a gingivitis.
Okay. How long after, I guess, be stopping Evenity treatment? I'm guessing that's what it is. Are you at risk for ONJ? How long after? I'm not sure if it's how long after stopping or how long after beginning. Oh, are you getting increases?
So is this a question you're reading from Philippa?
Yes.
Okay. So how long after Evenity are you at risk for ONJ? And then supposedly, once you're done with Evenity, I should go on Prolia. How long after Prolia should you wait for implants or extraction? So again, we can't really give individualized medical advice. Evenity does have a very short half-life. So typically after completing Evenity, it's safe to consider beginning one of these treatments if your dentist feels it's appropriate. With Prolia, we do our best to, Prolia is given every 6 months. And we do our best. If you had a shot of Prolia, we try to aim for having those treatments done between month 4 and 6 to allow for healing, and then a very limited delay of your next Prolia shot. Because of course with Prolia, if you're missing a shot or a shot is too far delayed, then we do risk losing bone density, in particular in the spine. So we weigh all of these things very carefully. We talk with your dental providers when we need to go ahead and try to plan out the best course of action for each individual.
Okay. All right. And I'll just reiterate also that I know there's a fine line between asking a personal medical question versus generalized. So try to keep it generalized. And as Cassie's saying, it's not her role or our role to try to do any treatment or provide advice regarding treatment. But in general, another question is here, this asked with some frequency from Suzanne. Are you seeing it, Cassie? Someone who hasn't taken drugs but has had some issues, so they seemingly are at risk for,
No, they're not more likely to have ONJ with Prolia. They would have similar risk. That's another one where your dentist would want to weigh in regarding your other potential causative factors that could affect your jaw health and potential ability to place new implants if that's something that's needed. But the Prolia itself, we would not expect to have a significantly increased risk of any issues.
Yeah. Okay. All right. Someone's asking, where's the raised hand feature? Along the menu on the bottom of your screen, there's a bullet that says reactions and a kind of a smiley face on it. If you click on the little arrow on the bullet, a screen will open and you can raise hand from there, and that should take your image to the front of the screen, and it does. So Marlene, go ahead and ask your question. Except Marlene, after you ask it,
Actually,
right now Marlene's whole name is being being recorded, which is not what we're supposed to do here. But all right, go for it, Marlene.
actually, that's a good one, because I'd like to change so that it's not on, my full name is not there, but I think my question has been answered. I'm sorry. I'm good.
That's okay.
Gonna listen. Very informative. Thank you.
Yeah.
You're welcome. No problem.
Okay. Oh gosh. Again.
I think Mary asked, what about bariatric treatments as a remedy? That would be a treatment that's needed only if you're having the most severe cases of osteonecrosis of the jaw. So if they're considering surgery, they may also consider a hyperbaric chamber type of treatment.
Okay, Sally, you need to unmute yourself.
Okay, sorry, I couldn't find the hand.
Okay.
Okay, first off, I want to say I have thoroughly enjoyed all these lectures. They have really helped me a lot because I'm really old, and I started way back when Fosamax first came out, and that was the thing to do, and so they put me on it. And after about 3 years or maybe 5 years, I don't know, all of a sudden, when you asked about symptoms, I mean, I know my body. I mean, I'm a nutritionist, and so I really pay attention. All of a sudden, I started drooling. I'm like, what is this? I don't drool. So, of course, I asked my girlfriend, who's a doctor, what's with the drooling? And she's like, there's no drooling. I said, of course, there's drooling. And then it went from all of a sudden a tooth got loose. Go to my dentist, who is top notch. And he goes, well, it must be TMJ. I said, I don't do TMJ. So I go from TMJ to TMJ to TMJ. They start doing a root canal. And as the root canal is being done, the guy says to my husband, I don't know why I'm doing this, because she doesn't need a root canal. So then I'm in LA. I see this advertisement by these lawyers saying it's because of Fosamax. So I called this guy. I said, I know you're an attorney. You're getting a bunch of people together to sue. I don't sue, but I want to know all the facts. So that's how I first heard about the association between the jaw, because the next thing I know, it locked on me. I couldn't talk. I couldn't eat. It was locked on me for like a week. Then I had to go to TMJ's to try and get my jaw working again. Finally, the TMJ attorney says, get off the Fosamax. So I got off the Fosamax, but it was a seek and hide. And my point being that with you guys, it's great to get the group together so you can hear these things, so you don't have to play hide and seek and trying to find, because I don't want to be a doctor. I want to find the facts from doctors. I don't want to search myself. And by doing these things, it's really great. My next question is, all right, I broke my hip because they said.
Excuse me, Sally, I'm going to have to interrupt because I'm trying to get through.
Okay, I just
have 22 new messages, so hold your question. I'm going to mute you there, and then maybe we can come back to you. All right, so maybe a quick response from for Connie. Did you say the odds of ONJ with bisphosphonates is 0.01%, 1 in 10,000?
Correct.
Oh, okay.
And I see another one from Jerry about, is it advisable to start Forteo if we're going to proceed with an implant? And then Philippa said, good question, I hope they answer it. So let me address that really quickly. It's really variable depending on your specific case. There is not adequate data at this point to say that we should or shouldn't be starting Forteo and Tymlos for an improved outcome with implants. Those typically are started for only patients who have severe osteoporosis. So it could be considered on a case-by-case basis, but it is not the standard of care as of now.
Okay. All right. Then Michelle, just to be clear, Forteo being similar to Evenity also has ONJ potential. Yes, no.
Wrong. So Forteo and Tymlos do work differently. Forteo and Tymlos, which is teriparatide and abaloparatide, they stimulate the osteoblasts. They do not interact at all with the osteoclast, whereas romosozumab or Evenity actually both stimulates the osteoblast and also blocks the osteoclast activity. So that's where we get this ONJ risk from that we do not see with Tymlos or Forteo.
Okay. I think this next question is probably more for your dentist, your dental provider. Is it a good idea to do a panoramic CT before getting a major dental done?
Yeah, that would be up to the dentist for sure. And that goes along with, your dentist is looking in your mouth. They're identifying areas of inflammation, pre-existing bone loss, need for other dental procedures on their end. So if they recommended one, then I think that wouldn't be a terrible idea, but not something that needs to be the standard of practice for everyone.
Is there any relationship between incidence of ONJ and femur fracture?
They are not causative in the sense that if you have one, you're not going to have the other. They do have similar incidence with similar medications. So we're planning to do another talk in the future regarding atypical femur fractures, but they don't go hand in hand. Both are very uncommon though.
Okay. So I'm skipping around a little bit here. What about bariatric treatments? Bariatric treatments as a remedy? I'm not sure what.
Yeah, I think I touched on that one. Hyperbaric chamber can be used for severe osteonecrosis of the jaw. That would go along with some of the dental procedures that they do in the most severe cases, which are pretty unlikely to be seen with osteoporosis.
Okay. Another question I think needs to go back to the dentist. Between a bridge and an implant, is it better to get a bridge? I think
Somehow we're now viewing Betsy's whiteboard.
Yeah.
Between a bridge and an implant, is it better to get a bridge? It really just depends on what your dentist advises. Of course, with the bridge, you're not going into the jaw. So yes, it's less invasive. But if you and your dentist decide that the implant is the direction that you want to go and you are on an osteoporosis treatment, as we've continually reiterated here, the risk associated with those medications is really low. So we don't advise you to go bridge or implant based on just your osteoporosis treatment alone.
Okay. Question from Marianne, straightforward question. Does having osteoporosis itself increase the likelihood of dental issues such as, she's asking, loosening of teeth? I guess we could put ONJ in there too.
So osteoporosis does not necessarily cause ONJ in any way. That is a treatment associated issue. Overall bone loss can be associated with osteoporosis. More commonly typically associated with aging, inflammation, infections in the mouth, gingivitis, that kind of thing.
Okay. Mary asked, and you might want to raise your hand, Mary, to clarify this. Would your endocrinologist or your oral surgeon be the one to make the final decision? And my question back to you is the final decision on what?
The final decision on whether you're okay to go ahead with a dental procedure. I didn't know whether they communicate. In your experience, do they talk amongst each other and get the whole picture, or does one say, I don't need to hear from them. If you are on this or finish this, this is what you should do. I didn't know if normally they communicate, because I haven't ever experienced having to go to one before, so I didn't know.
Yeah, we certainly can communicate with your oral surgeon if they want to hear anything from us. But generally, if we're talking about an oral surgery decision, that's going to be the oral surgeon's ultimate decision to move forward.
I'm going to ask this question.
Thank you.
More,
yeah.
Going to ask more, put this in generalized terms. Someone that might have some gum issues and hard to heal gum issues, is that a warning sign perhaps for ONJ?
It could be. So ONJ is associated with inflammation and infection in the mouth, which is your typical periodontal disease, gingivitis, that type of thing. So those do worsen your overall oral health. That's part of the reason why it can be really difficult to assume that any of the osteoporosis treatments are rooted in the cause of ONJ, because typically a patient may have a lot of inflammation or other dental issues going on that are the more likely causative factor.
Okay, thank you. All right, just checking on the time here. Any effect of radiation treatment for cancer to the neck with ONJ? Any association there?
There is an association. Both cancer and chemotherapy can increase your risk of ONJ. I don't know the specific statistics on that since it's out of my area of specialty, but they are associated.
Right.
Hi, honey.
I'm good.
I'm good. I'm listening to my bone health lecture. That's it.
Okay. All right. I just learned something new there, Cassie. So, let's see. Okay, Rebecca's question down below. Do you want to take that? It was mentioned that osteonecrosis can happen throughout the body. I think when you initiated treatment, that means. So
no, the osteonecrosis that we worry about as related to osteoporosis medications is the jaw only.
Yeah. Okay. All right. So is it kind of general practice to initiate an anabolic agent or bromosozumab to start if someone is planning on an implant?
No, it's not general practice. I think we touched on that one already. So hopefully that was adequately addressed. There is some data starting to form, but we don't have enough yet to substantiate recommending Timos or Forteo during any dental procedures.
Okay, all right. We might be getting to the end. Jerry has had her hand up for a while, so go ahead, Jerry. Unmute yourself, please, and ask your question. Try and keep it.
I think I tried to circle back and get Jerry's question, but let me know if you need clarification.
Thank you. So I had an extraction done and an implant was supposed to be done right afterwards, but after grafting was done, bone was protruding and my dentist said that I didn't have enough bone in there after all. It took a long time for it to heal and bone is still protruding. I can still feel it. I'm just wondering if that would be indicative of my susceptibility to osteonecrosis, because my dentist is very reticent about moving forward with the implant now. And so I'm wondering if his reticence is, accurate. Could this be a predictor of my susceptibility?
Not to osteonecrosis specifically, I wouldn't say. It's difficult to know without really having a full picture of what's going on both in your medical health and oral health. But he's probably not just concerned about the potential for ONJ, but the actual ability of the implant to heal successfully.
Okay.
Okay. All right, we've come
Thank you.
to, we've just a minute to go. We're really at the end of questions. One last question, I think I can address this one. It relates to exercise. A question from Brenda. Since our bones are weak and we are told to do strength exercise for our hips, our back, walking, etc., does it make sense to do some jog exercise such as clinching the teeth? And Cassie, you can chime in here, but I think the answer to that is no. However, it does make sense to do neck exercise, especially if you've got a little bit of arthritic changes and even some degenerative disc in the neck. In our program, we incorporate a few neck exercises, very light stretching. And I think a favorite is the turtle exercise. We call it the turtle exercise, where you put 2 fingers on your chin and you want to get yourself in a nice straight posture, and then gentle pressure for about 5 seconds, pushing your head toward the rear. And that's strengthening some of the muscles that get weak for all of us who sit at computers, sit and read with our head bent forward a little bit and our shoulders bent forward. And so that can really make you aware of trying to get your head in alignment with your spine, which can do wonders for your overall standing and moving posture. So with that, Cassie, any comments you want to add to anything there?
No, I would agree with that. I mean, you're getting actually a lot of exercise in your jaw just by your normal eating and talking and that kind of thing. So it's really not an area that we have too much concern about with bone loss. It's one of the strongest joints in your body, but definitely the neck exercises are an excellent idea.
Okay. All right. Well, thank you everyone for your participation. All of your questions, I think we must have hit on 80 or 90 questions today. And overall, thank you, Cassie, for a really informative talk and lots of good information, as some of our participants are saying here. Thank you for taking the time of your busy schedule to speak to our group. We greatly appreciate it, and all you're doing actually to help me with the navigating through the platform itself and so on. So, all right, so take care. So folks, another quick announcement. Next month, June, is going to be our last session until September. We have July and August we usually take off because we adhere to the academic schedule. And I have not yet scheduled a speaker. I've gotten so many requests to do a Q&A. And so we're thinking we're going to do a Q&A. I actually talked to Dr. Woods about it early this morning. And in my idea is to have a clinician, and that may well be Dr. Woods, a nutritionist, a dietitian, right? And an exercise specialist, right? And that may be me, or it may be a colleague of mine. So, and that would be, again, just Q&A. So you can come in with your questions. You might even, I'm just going to say you might send them ahead of time, but that might not be a good idea if they're coming at me from different to different emails and so on. So I'll hold off on that. All
And they
right.
do general questions. It's not a medical specific.
And yes, and again, it's kind of a fine line. At least try and frame your questions in a generalized manner that would be helpful to the group and not, a personal medical issue. All right. Okay.
Jean, can you just demonstrate the turtle exercise again?
Sure. I don't know if I stand if I'm on a side view, 2 fingers on your chin, head first, try to get it in line with shoulders. So, and when I say in line, the ear should be just above the shoulder. And again, many of us sit like this all day long, so that's just hard to do in itself. I can go on and on. We do a lot of shoulder rolls, pressing the shoulder blades back and down, but that turtle, just gently push, hold for about 5 seconds. So you're going to feel it in some neck muscles. You're going to feel it in these neck muscles here. And that's statically or isometrically contracting those muscles. And if you do 3 to 5 repeats of that, and maybe a couple times a day, I know a lot of people have told me that when they're in their car, if they're at a stoplight or in traffic or something, they'll do that with the head against the headrest. I don't advise doing it when you're driving, moving, but you can do it when
Well, thank you very much.
Okay. All right, folks, I'll close off here. Be well, stay healthy, and we'll see you next month. All right.
Thanks, everybody.
All right. Okay.
Thank you.